Hi there, my name is Joan Harris. I'm an instructor with the Advanced Studies in Critical Care Nursing program. This presentation is about mechanical ventilation. Mechanical ventilation is a mainstay treatment for critically ill patients and is therefore important as ICU nurses that we understand how and why it is used. This is a two-part presentation. In part one, we will be discussing indications, mechanics, terminology, and modes of ventilation. In part two, we will discuss complications of and weaning from mechanical ventilation. The objectives of this presentation are to become familiar with the indications for mechanical ventilation, understand the mechanics of mechanical ventilation, be comfortable with using common terminology associated with mechanical ventilation, and understanding when and why common modes of ventilation are used. Mechanical ventilation is the application of an external apparatus to facilitate gas exchange between the atmosphere and the alveoli. The goals of therapy are dependent on the needs of the patient. Common indications for mechanical ventilation include apnea, so the inability to initiate a breath can be due to CNS depression, such as might be seen with a severe head injury or a drug overdose, or it may be related to lack of muscle stimulation, as seen with a high C-spine injury or the use of paralytics. In this situation, a controlled mode of ventilation is necessary, which we will discuss in more detail later in the presentation. Another indication is acute ventilatory failure. In acute ventilatory failure, the patient can initiate breathing, but it is insufficient to maintain appropriate carbon dioxide levels in the blood. This leads to an increase in PaCO2 and respiratory acidosis. This is typically recognized with a pH of less than 7.25. Another indication for mechanical ventilation is in cases where the airway itself is in jeopardy. For example, an inhalational injury causes airway tissue to swell, effectively closing off the airway. In this situation, intubation via endotracheal tube or tracheostomy is required to maintain the airway, and typically minimal oxygenation and ventilatory support is required unless there is also underlying lung damage or a decreased level of consciousness. The last indication, hypoxic respiratory failure. So an inability to maintain sufficient oxygenation can be related to a disease process that causes a shunt or ventilation perfusion mismatch. An example of this is ARDS, where alveolar collapse prevents the oxygenation of blood passing through. The use of pressure-controlled ventilation with supplemental oxygen, high levels of positive end expiratory pressure, and inverse ratio can be used to increase oxygen levels. We will be talking more about this in the slides to come. Now let's review the mechanics of mechanical ventilation. As you recall from your physiology course, spontaneous breathing begins with the development of a negative alveolar pressure relative to atmospheric pressure. Typically, this is the result of the diaphragm flattening and the chest wall pulling away from the lung, increasing the size of the lungs and pulling air into the lungs. In the above diagram, you will see that at the beginning of inspiration, P-alv is negative, becoming more negative until it reaches a peak. At that point, the diaphragm relaxes and air moves out of the lungs as P-alv becomes positive. Knowing this, can you think of a few clinical conditions that would restrict a patient's ability to generate a negative pressure necessary to initiate the inspiration? Take a moment to pause the video and write down a few conditions. So paralysis of the diaphragm renders it unable to contract and flatten, would prevent the patient from generating sufficient negative pressure, as seen with a high cervical spine injury or drug-induced paralysis. Modern ventilators use positive pressure ventilation. Unlike spontaneous breathing, positive pressure ventilation pushes air into the lungs, and typically, P-alv is positive throughout the respiratory cycle. This is unfortunately one of the negative effects of positive pressure ventilation, as we will discuss further in detail in part 2 of this presentation. In the meantime, can you think of potential complications related to positive pressure ventilation? Again, take a minute to pause the presentation and think this through. One common complication of positive pressure ventilation is barotrauma. Other complications will be discussed in more detail in part 2 of the presentation. In order to better understand the types of modes of ventilators, it is helpful to know some of the mechanics of ventilators and how the different parameters are manipulated to best meet the needs of the patient. There are 3 parameters that determine the type of mechanical ventilation. The trigger is how the breath is initiated. It can be time sensitive or pressure sensitive. Time sensitive means that a breath is delivered according to a set rate, and therefore this mode is machine initiated and a controlled form of ventilation. Pressure sensitive means that the ventilator waits until it senses a negative pressure as a result of the patient initiating a breath, at which point it would deliver a breath. This mode is considered an assisted mode of ventilation. The limit is the set pressure or volume to be achieved and maintained. In this case, the healthcare professional would set a specific volume of pressure that the ventilator would instill. The cycle is the setting that indicates what signals the end of inspiration, such that the patient can exhale passively. Again, this can be done by volume, pressure, or time related, depending on the needs of the patient. In order to understand mechanical ventilation, it is important to understand some of the terminology used. Please see the Mechanical Ventilator Terminology handout, which was created as a resource for this material. So the abbreviation VT is tidal volume, typically 6 to 10 mils per kilogram of ideal body weight. F or RR is considered to be the respiratory rate. 12 to 20 is fairly typical, maybe set higher based on the patient's needs. VE or MV is minute volume, typically 6 to 10 liters per minute. FiO2 is the fractional concentration of inspired oxygen, and we titrate the PaO2 to greater than 60, and SaO2 is greater than 90. Centimeters of water is CmH2O. Is just that, centimeters of water pressure. PEEP or PEEP is positive end expiratory pressure and is usually set between 5 and 20 centimeters of water pressure. Another term used is also extrinsic PEEP. Auto PEEP is intrinsic PEEP, so that's the PEEP that comes about physiologically. PIP is peak inspiratory pressure measured. I time is the inspiratory time and is typically 0.8 to 1.7 seconds. E time is expiratory time. The IE ratio takes the I time and compares it to the E time, and typically the E time is longer, so 1 to 1.5. If the patient has the inverse ratio ventilation mode, then that would be reversed. We'll be talking more about that in the slides to come. A mandatory breath is a breath initiated by a patient or ventilator and ended by the ventilator. Same for both volume control or pressure control ventilation modes. A spontaneous breath is initiated and ended by the patient, as seen with pressure support ventilation mode. We will be discussing this more when we look at the specific modes as well. Now we'll look at common modes of mechanical ventilation. The choice of mode of ventilation is dependent on the patient's needs and in many cases clinician preference and equipment availability. First we'll look at assist control. In this mode, the parameters that are set are the tidal volume, respiratory rate, and FiO2. What's variable is the peak inspiratory pressure. So in this mode, the patient always receives the set respiratory rate and tidal volume. The patient can initiate a breath, but will always receive the same set volume. So, for example, if the ventilator settings were a respiratory rate of 16 and a tidal volume of 600, the patient would receive a minimum of 16 breaths per minute, and each breath would be 600 mils. If the patient initiated a breath in between the machine breaths, that breath would also be delivered at 600 mils. This mode is often used for patients with an impaired respiratory drive, such as seen with a decreased level of consciousness or post-anesthesia. One potential issue with this mode is if the patient is breathing at an elevated rate. For example, if the setting were, as previously mentioned, a respiratory rate of 16 and a tidal volume of 600, but the patient was breathing at a rate of 30 breaths per minute instead, the minute volume, instead of the minute volume being 9.6 liters, the patient will receive a minute volume of 18 liters. This is a significant increase. Can you think of how this would affect the acid-base balance? Take a moment to pause the presentation and come up with an answer. An increased minute volume could put the patient into a respiratory alkalosis, as the patient will be blowing off carbon dioxide. A low CO2 level leads to an increase in the pH, leading to alkalosis. Another issue with volume-controlled ventilation is that the patient is at risk for barotrauma, as the ventilator's goal is to instill the volume. If the compliance of the lung decreases, making it harder to instill that set volume, the pressure in the lungs increases and can lead to alveolar rupture. The next mode we'll look at is pressure control ventilation. In this mode, the parameters that are set are the respiratory rate, peak inspiratory pressure, and the FiO2, and what's variable is the tidal volume. Pressure control ventilation is similar to assist control ventilation in that it is a controlled method of ventilation, and the patient receives the set pressure and rate regardless of if the breath is initiated by the machine or the patient, the difference being that it's pressure instead of volume that is set. This means that depending on the compliance of the lungs, the tidal volume will vary. Because the peak inspiratory pressure of this mode is capped, the patient is less likely to have barotrauma. But the varying tidal volume means that an appropriate minute volume may not be achieved. As you will recall, minute volume is related to the PaCO2 and acid-base balance. It is important to keep in mind that this could lead the patient to become acidotic, as an increase in the PaCO2 due to a decreased minute volume leads to respiratory acidosis. The next mode we'll look at is pressure support ventilation. In this mode, the parameters that are set are the FiO2 and the pressure support. What's variable is the respiratory rate, the tidal volume, and the peak inspiratory pressures. So the patient sets the rate and the tidal volume. The pressure support augments spontaneous inspiration through the application of positive pressure at the onset of inspiration. The amount of work that the patient does is influenced by the amount of positive pressure applied. For this reason, positive pressure ventilation is often used to assist in weaning the patients from mechanical ventilation. In order to use this mode, the patient must have an intact respiratory drive. If the patient is unable to maintain an appropriate minute ventilation, then the patient runs the risk of respiratory acidosis. The last mode we'll look at is intermittent mandatory ventilation, or synchronous intermittent mandatory ventilation, which is the more common mode. In this mode, the parameters that are set are the tidal volume, respiratory rate, and the FiO2. And what's variable is the peak inspiratory pressure and the tidal volume, depending on if the breath is initiated by the patient or the ventilator. So this mode really is a combination of a AC mode with pressure support. The patient is guaranteed the set rate at the set tidal volume, but in any breaths initiated by the patient, the volume is variable depending on the ability of the patient to initiate and maintain the breath. This mode is generally more comfortable for the patient, and you are less likely to run into the risk of respiratory alkalosis as you would with assist control ventilation. It can be used as a primary mode of ventilation and during the weaning process, especially if the patient has atrophied respiratory muscles and requires more support from the ventilator. So this slide shows what the respiratory pattern would look like if the patient was on an SIMV with a set rate of 10 and a tidal volume of 500. Now, if the patient is not initiating any breaths, then the patient will receive just the set rate at the volume that has been prescribed. So this slide shows a case when both the ventilator and the patient are initiating breaths. So you can see here that the underlying ventilator rate is still set at 10, but the patient is able to breathe in between the assisted breaths. The spontaneous breaths in this diagram are consistently lower than the machine breaths, but in another situation they could actually exceed the set level. Can you think of how this might affect the minute volume? Take a minute to pause. So the increased rate and tidal volume would increase the minute volume, potentially putting the patient at risk for respiratory alkalosis. Two adjuncts to mechanical ventilation include positive end expiratory pressure, or PEEP, and inverse ratio ventilation. PEEP sustains a positive alveolar pressure at end expiration to help prevent alveolar collapse. It's often used to overcome the resistance created by the ET tube, so it's usually set at about 5 centimeters of water pressure, and that's standard for almost every patient. Higher levels are used to improve hypoxemia, such as in ARDS. We're going to talk more about PEEP in the next few slides. Inverse ratio ventilation, it reverses the inspiratory-expiratory ratio to values as high as 4:1. So if you recall from the previous slide when we were looking at terminology, the inverse ratio is usually 1 to 1.5, so we typically spend more time exhaling than inhaling. This means that the time spent inhaling oxygen is lower than the time spent exhaling CO2. Whereas with IRV, the ratio is flipped so that more time is spent during inhalation, which decreases alveolar collapse and allows for more complete alveolar inflation and diffusion of oxygen. This is useful in acute refractory hypoxemia arising from a shunt, such as in conditions such as ARDS. So PEEP is the application of above atmospheric positive pressure at end expiration. It prevents complete exhalation, increasing the volume of air in the lungs at end expiration. And the alveoli remain more inflated than if pressure was allowed to fall to 0 as we would normally. So you can see in the diagram here that the level of, with respect to the curve, it never goes below 5. So it always ends up being a little bit positive. So as previously mentioned, PEEP is applied to overcome the resistance of the ET tube at about 5 centimeters of water pressure. That's a common setting, and again, used with almost every patient. But the higher levels are applied to prevent alveolar collapse and recruit previously collapsed alveoli, thereby increasing alveolar volume and surface area. It also aids in the redistribution of excess lung water from the alveoli by pressure. Ultimately, the goal of higher levels of PEEP is to increase the number of alveoli available to participate in gas exchange, effectively decreasing the shunt. Some of the disadvantages of PEEP is that it increases the mean airway pressure. This is an increase in the average pressure transmitted to the lungs by the ventilator, and it predisposes the patient to barotrauma. This causes injury to the alveolar membrane, as well as can actually cause a tension pneumothorax if an entire lobe is affected. It also increases intrathoracic pressure, which results in decreased venous return to the right side of the heart, and this in turn decreases the cardiac output and oxygen delivery. This concludes part 1 of mechanical ventilation presentations. Part 2 will be looking at complications and weaning of mechanical ventilation. If you have any questions about the material covered here, please contact your instructor. Have a great day.